introduce our last speaking group, a dynamic duo, uh, Dr. Samantha Hahn, Ph.D. and Ph.D., and Dr. Jesse Bakke, Ph.D. First, I'll talk about Dr. Jesse Bakke. He's an associate professor of biochemistry and nutrition, the Department of Foundational Sciences at Central Michigan University College of Medicine. He obtained his BS at the University of Hawaii Manoa in food science and human nutrition, and his PhD at the University of California, Davis in nutritional biology, which I have to say is an excellent school for nutrition. So kudos to you. He completed his postdoctoral training at St. Jude's Children's Research Hospital. Professionally, he is a member of the Michigan Medical Nutrition Education Consortium and the treasurer for the Association of Biochemistry Educators. He has expertise in cell signaling, particularly kinase and phosphatase signaling and metabolism. Dr. Samantha Hahn is an associate professor of nutrition and epidemiology at Central Michigan University College of Medicine and a registered dietitian. She obtained her BS in nutritional sciences and human biology from Michigan State University, her master's of public health in nutrition and dietetics, and PhD in nutrition epidemiology and nutrition intervention from the University of Michigan School of Public Health. Following her graduate work, she completed an NIMH T32 postdoctoral fellowship in eating disorders epidemiology at the University of Minnesota. Her work in eating disorder prevention, and particularly her work aiming to understand how clinical and public health practices impact eating disorder risk, has been recognized by international organizations, including being inducted into the Eating Disorder Research Society. So with that, I welcome you, and I really look forward to your talk.
Thank you. Dr. Hahn, can you go ahead and make that full screen for us? While she's trying to get that into presenter mode, I'll go ahead and get started. So I'm very happy to be here today with you guys. Quite surprised to see the big number of people that are online. And I think it's really important topic. So today we have me and Dr. Hahn are going to be talking about eating disorder risk with relation to intermittent fasting. I do not do eating disorder research. My research is much more cancer focused. But I kind of want to tell my story of how I became aware of this other side of the intermittent fasting or time restricted eating. So go next slide, Dr. Hahn. So overall outline of our talk today is I'm going to talk about my personal change of perspective, and then we're going to hand it over to Dr. Hahn, and who's really the expert on eating disorder field in general, where she's going to introduce eating disorders, talk about the overlap of intermittent fasting and disordered eating, if there is any, what data we have right now, and then how can we consider disordered eating when recommending or testing for intermittent fasting. So my personal introduction, or really the reintroduction. So here's my, I had a very kind introduction from Leo, where my bachelor's and my doctorate are both heavy nutrition focused. And so you'd think that someone with my education would be kind of well aware of the disordered eating and eating disorders within, changes in eating habits. But that's not the case. And I've been teaching human metabolism to students for a long time. I have a lot of students interested in eating intermittent fasting. I've been personally doing intermittent fasting myself for over 10 years, so probably 14 years now. And so I have a huge interest in this. And yet I had a major blind spot in relation to some of the risks of intermittent fasting or time restricted feeding or time restricted eating with patients. So one of my students approached me wanting to publish a review paper on intermittent fasting. So we did that, just addressing it towards clinicians. One of the most classic areas of intermittent fasting that we heard about earlier today is about its role in diabetes prevention. And there's a lot of strong evidence suggesting that it does play a role, and it makes sense scientifically, it makes sense signaling wise and metabolically. And so we published that, and then right after we published that, we can go next slide. Dr. Hahn joined our university as a brand new assistant professor out of her postdoc. And we got talking because we're friends. And I very quickly realized I had a major blind spot. I did not consider that some of these patients that these clinicians, that all my students are going to be talking and doing motivational interviewing, that kind of stuff. and talking to them about intermittent fasting and other changes in eating behavior, that I was not considering the risks of disordered eating. And so I very quickly with Dr. Hahn, we did an amendment to our publication. There was a commentary, this making sure that we do discuss the risks of disordered eating in these populations of people. So with that, I will hand it over to Dr. Hahn. So hopefully your story will be similar to my story, and that we get to have a little bit of the realization that not everything, even though signaling wise is a lot of roses on that side, scientifically time restricted eating is very beneficial in a lot of respects, but there is a little bit of a consideration that we need to make on our personal lives, and especially if we're going to be advocating for this type of eating behavior to others that may not share the same risk factors as other people. Dr. Hahn?
Thanks, Jesse. So I am going to be kind of talking about IF from an eating disorder perspective. So I want to give you my perspective in terms of my training and everything like that. I was trained in an eating disorder lab. I kind of came into nutrition like everybody else. I did an undergrad in human biology and nutrition, and then I did um, my PhD in nutrition and everything like that. But I was trained in an eating disorder lab. And so I think that really makes a difference in terms of how I saw nutrition. So I am a registered dietitian, but I do think it's important to acknowledge that even in my early aughts of training, I was trained in an eating disorder lab. So all of my training in terms of how do we promote healthful eating came from this eating disorder perspective. My dissertation, my postdoc, all of that is really looking at how do we promote healthy eating while simultaneously preventing harm. But excuse me, my daughter is sick and she gave it to me, so I apologize if I am hard to understand. Um, because not all of us were trained in eating disorder labs, I just want to make sure that we're kind of all on the same page in terms of eating disorders 101. So, eating disorders are psychological disorders characterized by extreme beliefs, attitudes, and disorders surrounding food, weight, size, and/or shape. They have very strict diagnoses in terms of DSM, disease and statistic manual diagnoses. But these, excuse me, eating disorders have extremely high morbidity and mortality. So, folks who are struggling with an eating disorder are really struggling in all aspects of life. They are struggling in terms of like everyday aspects, what they're dealing with on a day to day is really hard. And so, I'm so sorry. um, what they're dealing with on a day to day in terms of morbidity is far beyond what we typically think of. And then in terms of mortality, eating disorders have a far higher mortality rate than people really think of. So eating disorders have the second highest mortality rate um, of any uh, mental health illness, second only to opioid use disorder. So, opioid use disorder has the highest mortality rate, but then eating disorders, specifically anorexia nervosa, has the second highest mortality rate of any eating or any mental health illness. And when we think about what causes eating disorders, it's actually very complex. We can't kind of signal one thing as causing eating disorders. It's a range of biological, there's genetic components, psychological, there are certain traits that make folks more or less likely to develop eating disorders, and then sociocultural. So things like engaging in social media or believing that um, having a certain body is more or less ideal. those things all impact somebody's likelihood of developing an eating disorder. But again, they are far more common than people typically think. So about 9% or 30 million people in the US population will struggle with a full syndrome eating disorder in their lifetime. But many, many, many more will have disordered eating. So, what do I mean by disordered eating? Disordered eating is really this kind of encompassing term of engaging in eating disorder behaviors, irrespective if somebody meets criteria for a full syndrome eating disorder. So, many people will engage in disordered eating, things like fasting, which is particularly relevant for today's conversation, purging, compulsive exercise, binge eating, disordered muscle building behaviors, but they might not meet these diagnostic criteria for an eating disorder. So, as I mentioned, eating disorders have these full threshold diagnostic criteria of engaging in these specific behaviors a certain amount of times and a certain amount of period. For example, it's three binge episodes in 3 weeks, for example. So just because somebody engages in 2 binge episodes in those 2 weeks doesn't mean that they're struggling less. It just means that they aren't meeting these very strict criteria for an eating disorder. So when I talk about disordered eating and eating disorders today, I'm going to be kind of broadly referring to disordered eating. I'm going to be talking about folks who are engaging in these eating disorder behaviors, irrespective of if they meet these criterion for a full syndrome eating disorder. Because irrespective of if they meet these full syndrome eating disorder cases, they're still suffering. So everybody with disordered eating is struggling, but not necessarily everybody who has a full syndrome eating disorder meets criterion for, excuse me, not everybody with a full syndrome eating disorder. I said that backwards again. I'm so sorry. Not everybody with a full syndrome eating disorder, um, not everybody with an disordered eating meets criterion for a full syndrome eating disorder, but everybody with an eating disorder is engaging in disordered eating. Irrespective, people who are engaging in disordered eating are struggling. They are suffering both mentally and physically because disordered eating is both mentally and physically cumbersome. And to give you an idea of some of the consequences of eating disorders and disordered eating, just so you can see how severe it is, I want to kind of lay out some of these criterion. So some are psychosocial in terms of shame or guilt. Everybody who engages in disordered eating has these shame or guilt cycles and engages in withdrawal from friends or activities. So folks who are binging are trying to hide those types of activities from other people. And they have decreased educational attainment. So folks who have disordered eating are less likely to go on to engage in educational activities in terms of um, going on to college and even going on to a full-time employment. There is decreased cardiopulmonary activity, low pulse and blood pressure, and even on the opposite end, high blood pressure, abnormal electrolytes. So this is something that we have to worry about, particularly for folks who engage in binge eating episodes. So we have to worry about fasting and then um, afterwards worrying about how those individuals are engaging. I'm so sorry. how those individuals are engaging in binge eating episodes and then afterwards refeeding episodes. So individuals who are particularly starved are more likely to have abnormal electrolytes afterwards. And then musculoskeletal decreased body fat and muscle mass is particularly common among individuals with anorexia nervosa, but low bone density is common among individuals with anorexia nervosa, but also not anorexia nervosa because the calcium and vitamin D deficiencies that are particularly common after folks engage in binging and purging. Those folks are more likely to have low bone density, even if they do not have low body mass index, which is important to note. Marked changes in malnutrition and body fat. So even folks who are not engaging in or do not experience low body weight can still have major changes in body fat and malnutrition. So just because somebody is not low body mass index does not mean that they are not malnourished. And that's an important note that I think in particular folks who are in the nutrition field, we tend to think about folks who are malnourished as being low body mass index, but in particular in eating disorders, it's important to think about folks who are across the weight spectrum. And then skin, gastro, and other endocrine disorders. Gastro in particular is very important because folks who have eating disorders often kind of present in terms of the nutrition world in non-primary care places. They often present in gastro places in terms of having indigestion, slow GI presentation, etc. And that's a very important place to kind of flag if this is happening. Is it really an eating disorder, or is it these other types of things that are happening? The other thing I want to highlight is that in eating disorders, we often think about what we call the swag stereotype. So in eating disorders, we often think that skinny, white, affluent girls are who has eating disorders, but this couldn't be farther from the truth. Eating disorders affect everyone. And in fact, they actually affect people who are very displaced from that swag stereotype more often than not. So they affect all genders and sexes and all sexual orientations. And in fact, LGBTQ folks are more likely to develop an eating disorder than heterosexual cis folks. All races and ethnicities, and in fact, folks who are BIPOC are more likely to develop an eating disorder, particularly binge eating and compensatory behaviors than white folks. So white folks are more likely to develop, behaviors like skipping eating or skipping meals and those type of behaviors. But again, binge eating and compensatory behaviors are more likely among BIPOC folks. All financial backgrounds. So my interest is actually in understanding eating disorder risk in low SES populations and particularly rural populations. And what we found is that low SES populations are more likely to develop eating disorders. So again, counter to that swag stereotype of skinny affluent folks. Affluent individuals are far more likely to receive diagnoses and far more likely to receive treatment, but they are less likely to develop eating disorders, counter to that swag stereotype. And then all sizes and shapes, again, counter to that swag stereotype. Individuals who are larger bodied are far more likely to develop an eating disorder. In particular, binge eating and compensatory behaviors are far more common among individuals of larger bodies. And then all ages, which I'm actually going to talk about in a little bit. But I think it's really important to highlight here that there is a disproportionate burden on marginalized groups. And again, that swag stereotype could not be farther from the truth. But how common is disordered eating? In high schools, so using their youth risk behavior surveillance system, 15.2% had fasted, used diet pills, or vomited in the 30 days prior to survey. So a huge proportion of adolescents are engaging in disordered eating. And then when we look at this kind of transitionary period from high school to adolescence, we see another large increase. So first year college students, we saw that 15% had fasted for 24 hours or more. So not just the, intermittent fasting kind of period, but 24 hours or more. 58% had skipped meals, 12% had purged, meaning they vomited, used diet pills or laxatives. 52% had excessively or compulsively exercised, and 51% used supplements of some kind, specifically protein powders, steroids, or another muscle building kind of product. And when we look at the undergraduate and graduate population more broadly, 49% of women and 30% of men had binge eaten, and 31% of women and 29% of men had used a compensatory behavior. But I think it's important to recognize that disordered eating, yes, we definitely think of adolescence and young adulthood as this kind of peak period, because certainly it is when we see this period of the highest prevalence. But there's also this kind of bimodal characteristic in midlife where we see um, another peak of disordered eating and other types of unhealthy weight control behaviors. And the reason that we see this is, broadly, when we think about disordered eating, we are thinking about diet culture. We are thinking about the influences of why somebody might engage in this type of eating or weight-related behavior. And the big driver is this underlying idea that thin is good and fat is bad. In particular, this really is becoming kind of quote unquote true or resilient in these bimodal characteristics. So in adolescence and young adulthood, we have a lot of people who are um, engaging in like things like social media, and they have a lot of people telling them like you should look a certain way, your body should look a certain way, and if you just try hard enough, you can look that way. And if you don't look that way, it's your fault. Um, and you can use makeup or filters on social media, etc., to meet this beauty ideal. But the underlying idea is this thin and muscular ideal is good and fat is bad. And by and large, when we're seeing these bimodal occurrences, is actually when we're seeing deviations in our natural ability to meet these ideals. So in adolescents, particularly girls, they're gaining adipose tissue, right? They're going through puberty and they are getting more adipose tissue, and that is taking them away from this ideal of thin, of if I just achieve super, super thin, then I will quote unquote be attractive. But this also happens later in life, right? Folks who are going through menopause or um, later in life, they are having hormonal switches that are making them um, more likely to gain adipose tissue around their midsection, more likely to gain adipose tissue irrespective of where they gain it. And this is drawing them further and further away from this like ideal of a curvy ideal, a thin ideal, and more towards this like quote unquote fat is bad. And they think more and more that this fat is bad is because they are doing something wrong. But in reality, um, we all know as researchers that our ability and our ability to lose fat and maintain fat loss is so hindered on genetics, on, I mean, really everything, right? So we are not able to maintain weight loss in the sense that society tells us we should be able to maintain weight loss. And so we internalize this inability to maintain weight loss as our own personal failings. And so we think we are bad because we can't maintain this weight loss. And in particularly later in life, when folks are in particularly focusing on intermittent fasting and trying to lose weight, they are not actually biologically capable of losing and maintaining this weight loss, and they internalize it as their own moral failure. So now I want to talk about kind of the overlap of disordered eating and intermittent fasting. And I know this is going to be kind of controversial, and I welcome any and all thoughts, but disordered eating is harmful eating and weight-related behaviors specifically to change weight and or shape. And that includes fasting. And then intermittent fasting, on the other hand, is skipping meals and fasting, this time-restricted feeding. So you can see that they do overlap in many senses. So when done for weight and shape purposes, intermittent fasting is by definition disordered eating. And I know, again, this is going to ruffle some feathers, but it is this definition of the motivation that folks are having. Why are they intermittent fasting? Is it for weight and shape? Is it for metabolic health? This is all very dependent. And we know that in other kind of fields like physical activity, the reason that somebody has engaging for, say, physical activity has an extreme effect on the outcomes associated with that behavior. So, for example, physical activity is associated with very different health behavior outcomes if somebody is engaging in it for weight and shape purposes versus kind of these day-to-day effects in terms of, I want to feel better. But it's also important to know that irrespective of if we considered intermittent fasting disordered eating, IF can also lead to other forms of disordered eating be above and beyond that fasting component. And particularly this restriction and binge cycle. So in this restriction, you have a low calorie or food limited groups. Again, this is going to be that restriction, folks engaging in that restriction specifically for intermittent fasting. But for some folks, that leads to feelings of feeling deprived or hungry and feeling an increased urge to eat. And that can actually lead to episodes of binge eating. So feeling out of control around food or unable to stop eating. In particular, a binge eating episode is characterized by two things. First, eating a large amount of food, an objectively a large amount of food, and then two, feeling a sense of loss of control during that eating episode. And in fact, we have seen in my own research that intermittent fasting has led to binge eating episodes. So this was a mixed method study where we followed folks in over time to see how weight-related self-monitoring, so things like using MyFitnessPal, Fitbit, impacted their disordered eating risk. And folks in this mixed method study, particularly the qualitative portion, so the interview portion, reported that when they were engaging in time restricted feeding and particularly intermittent fasting, that they felt so kind of restricted and like they, were restricted not in terms of just the quantity, but the quality of their eating, that they went on to engage in binge eating, whether or not they called it binge eating. And then, beyond just our qualitative research, which I know some people have some qualms about in terms of, is there temporality? Did the binge eating actually, or did the time restricted feeding actually lead to the binge eating? We have another study by Dr. Ganson and folks in the Journal of Eating Behaviors, and they looked at a general population. And this is, again, a cross-sectional study, so we're not able to assess temporality, but they found that in the general population of emerging adults, ab about 50% of women and about 40% of men engaged in time restricted feeding or intermittent fasting in the last year. And in the last 30 days, it was about a quarter of folks. So intermittent fasting is not just this clinical tool anymore. It's not just this very restrictive, we're getting so much instruction about intermittent fasting. It is now transcended into the general population, and folks are engaging in intermittent fasting with or without the tools that they need to do so safely, because 50% of women are engaging in this type of behavior. But it's also important to note that intermittent fasting in this general population was associated with high rates of eating disorder risk. So in the population of women specifically, we saw that folks who had engaged in intermittent fasting in the last 12 months were more likely to overeat, have a loss of control eating, engage in any binge eating, vomiting, laxative use specifically for weight and shape control, have any compulsive exercise, fasting, or kind of a global EDQ score that would signify that they were high in eating disorder risk. So in particular, I want to draw your attention to laxative use. So folks who engaged in intermittent fasting were 3 times more likely to engage in laxative use compared to those who had not engaged in laxative use. So irrespective of how somebody is engaging or whether or not it is causing an eating disorder, we are seeing very, 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 very high rates of disordered eating among those who are engaging in intermittent fasting. In fact, 3 times the rates. And this might be because of a population overlap for sure. We're not able to look at causality in these types of research studies. So IF is recommended for weight loss among those with larger bodies for sure. We've heard here today that IF is particularly good for weight loss, and people do end up losing weight if they are engaging in intermittent fasting. But we also have to think about kind of this overlap. And those with larger bodies also have higher eating disorder risk. Again, counter that swag stereotype. Folks with larger bodies have higher eating disorder risk, which means they are more likely to engage in disordered eating, and they are more likely to have things like binge eating episodes as a result of intermittent fasting. So kind of contradicting our own stereotypes and thinking about who has eating disorders and disordered eating. It's also important to note that dieting is a potent predictor of future eating disorders. So when we look at who goes on to develop eating disorders, dieting is the #1 predictor. Folks who go on, or folks who are dieting, are the most likely to go on to develop an eating disorder. So if we are recommending dieting in some sense, that is problematic. And we can think about the folks that we are recommending dieting in the form of IF are the most likely to go on to develop an eating disorder or disordered eating. So we need to kind of think about our follow-up with those folks. And because of popularity and reported benefits, IF is just not solely in the clinical and supervised spaces. My line of research is really looking at how do clinical, these clinically used tools impact the general population in terms of calorie counting and intermittent fasting. We recommend them at an individual level, but because we are so ecstatic about the potential consequences and the potential use of these things, they often transcend into our own individual recommendations. So it's not just the people that we are recommending use these things. It's also the general population that is hearing about how great these tools are, and then they are going on to use these things. So we need to think about how does our messaging impact not only the individuals that we're recommending, but also the broader population that we may be recommending to. We also have to think about among those with high levels of eating and weight related concerns, those are probably who we are recommending IF to in terms of folks with diabetes, folks with higher body weights, folks with hypertension. Again, these are not just individuals who are left in their own in society. They live in this weight stigmatizing culture. And so they are being told that their body is the problem. They have their own feelings and thoughts about their weight, and they are likely being fed the messaging, if not by their own selves, by other individuals, their doctor, their loved ones, that they need to lose weight. And so if we are thinking about intermittent fasting and who we're recommending that to, it's probably also the individuals who are told they need to lose weight and therefore are getting all of these other messages that could increase their eating disorder risk. But irrespective, I think this really boils down to whoever we are giving intermittent fasting advice to on a clinical level, on a population level, we need to be very, very careful on if and how we recommend IF in terms of we have to think about the potential consequences. For sure, there are benefits, metabolic benefits, as Jesse has taught me many, many times. But I also think about the flip side of the coin, right? In terms of who might this harm? And we can't just think about the benefits. We also have to think about the harms on an individual level, but also population level, right? And in particular, I can say in our medical students often hear about all these potential benefits of intermittent fasting and they think it's just all good, right? And I think that's kind of consequential of all of the messaging around intermittent fasting. It's all beneficial, but in reality, we have to think about this flip side of who might it not be helpful for, and really advocating for those folks, because I think oftentimes the folks that are not advocated for in terms of who it might be harmful for are who's not receiving advocacy in general. So I already talked about this, but consider your broad messages when communicating benefits of IF in terms of this is just like an AI generated news article in terms of communicating, oh, IF is great. I think IF can be great, but we also need to make sure that when we're communicating the benefits of IF, that we are also telling people it might not be beneficial for X, Y, and Z folks for this reason. We want to make sure that we're not just saying it's great for everyone because it's not. If you're a clinician, I really advocate for universal screening and, in fact, rescreening of folks with disordered eating. So if you're advocating for intermittent fasting, we want to make sure that we're not advocating for intermittent fasting for folks who are struggling. And I included 2 screeners here, the ESP and the SCOFF. The ESP is 5 questions. SCOFF is also 5 questions. They both have very, very high sensitivity, not so much specificity, but that's okay. I would rather have high sensitivity than specificity. But they're yes/no questions and are really effective. I also recommend being familiar and having information ready for disordered eating resources, right? So if you acknowledge that somebody has disordered eating or is struggling, that you can send them somewhere. And in particular, NEDA, the National Eating Disorder Association, is a really good resource. So they have online screenings for everyone, can tell you if they think that you meet criteria for an eating disorder or not. And then even further beyond that, it can connect you with local resources. So folks in the community who are NEDA certified, and then more broadly. And then for researchers, which I think is kind of probably more the folks in the room, I included this QR code. It is for the EDQ, which is a kind of the gold standard in eating disorder research in terms of measuring eating disorder risk. It is 28 questions, which I know is not ideal, but they do have a 12-question version and a 7-question version. And I recommend using this because it really is important for long-term follow-up. In particular for intermittent fasting, we see that when folks lose weight, at least temporarily, we see decreases in eating disorder risk and body dissatisfaction. But as we know, body dissatisfaction, weight gain, all of those things tend to come on later on in follow-up. So as folks gain weight back, because we know that weight loss is not particularly effective long term, as folks gain weight back, their body dissatisfaction increases and their eating disorder risk increases. So we want to make sure that we're not just measuring eating disorder risk pre-post, but we're measuring it long term so that we can really see how these things and our interventions impact eating disorder risk long term. We also want to make sure that we're not just measuring kind of our standard eating disorder behaviors in terms of restriction and fasting. We want to make sure that we're using more of a gender inclusive term. In particular, intermittent fasting is very common among folks trying to gain muscularity, and the EDQ and many eating disorder questionnaires do not assess disordered eating behaviors specifically for muscular orientation. So things like steroid use or protein powder use, etc. We want to make sure we're using kind of a more inclusive measure. And we want to make sure that we're measuring cognitions, not just behaviors, because as I said, cognitions can kind of rear their head long before cognitions do. That's all I have for you. Thank you. Jesse, anything else?
Nope. All right, I'm good.
Great, thank